Welcome to Mic'd Up with ChiroUp. I'm your host today, Brandon Steele. I'm going to say a few genuinely nice things about Tim today. So naturally, I had to leave him off the show to preserve the integrity of the podcast. In all reality, this podcast was supposed to be one research study from our research section in ChiroUp, and it turned out to be an entire episode. So I'm going to cover this one by myself. This episode was really an unexpectedly valuable topic because it exposed a really huge blind spot in my understanding in neurobiology and really focused me to close the loop in my research and then kind of find out how to talk to you about it. So, I think this is really where if you're honest with yourself, the best clinical learning happens somewhere between our confidence in the treatment room and then public embarrassment when we think we know something, but we really don't know the whole story. So that's really what today's podcast is going to be about. And I'm going to give you kind of the title behind the podcast first, which we really don't ever cover. It's in the show notes, but for this one, it really does tell the entire story of the podcast. So the title is When Symptoms Tell the Story Before the Orthopedic Exam Does. And the reason I chose this one is because if you've been listening to this podcast for a while, Tim and I, our practice is orthopedic evaluation, manual therapy, manipulation, exercise prescription for really most every patient. And then we spend the rest of our time educating our patient on their condition. So hopefully they can help us help them get out of pain or whatever their problem may be. However, one of my biggest mistakes that I make is assuming the orthopedic examination is the main character in this patient encounter. Because in reality, before I see the patient, I get their subjective. I see a survey of all their signs and symptoms. And really those symptoms kind of whisper the diagnosis long before the test reproduces it. And I think this is one of the interesting parts about patient care is the body doesn't simply produce pain. We don't have a low back fairy that comes down and taps someone on the shoulder and gives them pain. But in the same token, different nerve fibers within a nerve can create distinct experiences. And that's what I want to talk about today, is that understanding how the different fibers in a nerve are impinged, they're stretched, they're injured. But when you can understand what's happening by the signs and symptoms, we can really predict the severity, the chronicity, and really even the prognosis of a condition before we do orthopedic evaluation, before we do any advanced imaging, before we do any kind of provocative testing. So in this podcast, I'm going to break down some of these useful nuggets. I'm going to break them down into really 3 layers or 3 topics within, let's call it practical neurobiology and physiology that we can all understand to help us in patient care. So the first topic I'm going to go through is the types of nerves, and not just because we know all the types of nerves, I get that, but how do different diagnoses masquerade when it comes to a motor nerve being compressed as compared to a sensory nerve compressed, and there's some interesting pieces in this that I want to cover. Second, I want to cover what does it mean to you, and what can we relay to a patient that has constant symptoms versus intermittent neurologic symptoms. This is a big one, so I want to cover this, and this is going to be important as far as our understanding of nerve injury, and then most importantly, nerve recovery. And then finally, we're going to go through location, because here's why Tim is not on this podcast, is because he was actually right when he was telling me about something that I thought was incorrect, and I couldn't bear to have him on the show and have him look at me with that grin being like, I gotcha. In all reality, the location of the nerve being pinched is extremely important. And I'm going to explain this because the nerve biology at the intervertebral foramen is actually different in structure and function as compared to what that nerve looks like as it traverses down the upper or lower extremity. So once I'm kind of done with this, I think that hopefully we can have a clear understanding of nerve injury and, more importantly, nerve recovery, and start to isolate where these nerve problems may be. Now, once I'm done with the clinical part, which is those 3 things that I just talked about, I'm going to take an exciting detour into an upcoming change change to the podcast that realistically has been repeatedly requested. It's been heavily suggested, more by my team than anything, but now is going to be delivered. And so, yes, I'm giving in, but under very specific conditions, and I'm going to give you the details at the end of this show. All right, let's dive into the clinical topic, because this is really where the idea behind this podcast came, is understanding the types of nerves. Now, I'm going to cover sensory and motor, but I'll do this very quickly, and then I'm going into why it really matters. We all know sensory nerves are built like a, let's call it a layered communication system. We have our large myelinated A beta fibers. Those are going to be our touch, our vibration, our pressure nerves, our sensors. And then we're also going to have our smaller A delta fibers that are going to transmit sharp pain, fast pain, cold sensation, those kind of things. And then finally, our tiny unmyelinated C fibers are going to give us our dull, aching pain, our burning, our itching, our temperature. They can also be involved in autonomic responses. And really, when these start to get compressed, it takes a lot of compression. So you're going to start to see bizarre patterns and symptoms because you're getting a lot of different fibers. Now we got our bigger boys, our motor fibers, our primarily large alpha motor neurons. They're going to be our skeletal muscle contraction, and then our gamma fibers are going to be our muscle spindle sensitivity and tone. Now, the purpose behind this is not to take you through part 3 boards. The purpose is to understand that as we understand which nerves are being compressed, it gives a better idea of the diagnosis. So what I want to focus on are 2 very similar diagnoses coming from 2 distinct areas but can overlap in symptoms. And if we understand which diagnosis it is, it can really help us in our treatment of the patient. So the 2 diagnoses that I'm going to cover are notalgia paresthetica, and then I'm going to dive into long thoracic nerve neuropathy. And so first, notalgia paresthetica. This is one of the sneakiest conditions hiding in plain sight that I see. And really what I want to focus on is when you get the symptom of itchy back, discomfort going along the skin. They feel like it's dry skin, but you look on the area, there's no shingles, there's no skin findings, there's no rash, there's no anything. But it looks like it smells like it, they feel like it's an itch. And really what this is in notalgia paresthetica is in that medial inferior scapular area, usually involving the nerves between T2 and T6, is patients get a burning, a tingling, and numbness, a crawling sensation. I've actually had it described to me. And this could be months to years, and they can actually get skin changes because of autonomic responses from these compressed nerves. It's been going on for a very long time, and no one diagnoses this correctly. They suspect the mechanism of injury for notalgia paresthetica is irritation to the cutaneous branches of the posterior rami of anywhere between T2 and T6. It could be from spinal degeneration, it could be from paraspinal muscle tension, but really, if we know this as chiros, what do we do to help these areas? Obviously, manipulation, manual therapy, and exercise help out significantly. In fact, a 2020 BMC study found that 87% of people with notalgia paresthetica have cervical degenerative findings. And this is a big deal because that's where we should perk up. Because if you're having an itchy sensation, we can dive into the cervical and, most importantly, the upper thoracic spine to help relieve that stiffness, take compression and irritation away from those posterior rami of the T2 through T6 nerves, because itching, really as a primary symptom is kind of one of the strangest alarm symptoms in medicine. Pain is pretty normal. Itching kind of tells us we have a small fiber sensory response rather than a classic inflammatory response or nerve injury. So we have to be thinking about what nerves actually create that siren. If we have a pain siren, it could be any one of the nerves, but an itch siren really focuses on a sensory nerve and could help us delineate between any other diagnosis and notalgia paresthetica. Now, the cool part about notalgia is that this is one of those things that I found 2 case studies, which is where this podcast came from, that manipulation and myofascial release significantly help that diagnosis. So if you want the resources on this, obviously, the condition report, the condition reference, and also our research hub in ChiroUp, that now the research hub is actually shareable with friends. So if you log in, you can actually get all these references. There was another 2021, 2022 case report that also used manipulation and myofascial release, but then again followed up with exercise. is. And I think this is one of the biggest pieces, is that if the treatment is going to be mobilization, whether it's manipulation or mobilization, we need to be doing something when the patient's not in our office that's going to help them continue that mobilization. Just like I said, there is no back pain fairy that comes down and touches you on the back and says, you're going to have pain today. The same thing happens with this. Notalgia paresthetica didn't just randomly happen on a Tuesday. This is years of poor posture and immobility and looking at a computer screen. Yes, we can get things moving as chiros. However, the true art is teaching the patient why this happened in the first place and then showing them some strategies to help prevent this from happening again. Now, for the sake of this blog, I wanted to bring up the types of nerves and this diagnosis for one specific reason, is because notalgia paresthetica and long thoracic nerve neuropathy are in the same neighborhood, but they're different criminals, because these two different diagnoses have two different nerve fibers. So one of the most fascinating parts about notalgia is that it overlaps with long thoracic nerve neuropathy, because the same body posture, same activities, the same immobility can cause both of these. Now, long thoracic nerve issues is actually a little higher in the cervical spine, C5 through C7. And the cool part about this diagnosis is that I shouldn't say easy, but it has a characteristic symptom, or I should say sign, associated with it. So when you compromise the motor dominant area of the long thoracic nerve, it's going to create shoulder fatigue. It's going to create loss of overhead endurance, difficulty pushing, scapular instability, medial scapular pain, weakness during elevation. And the reason is because this area, this nerve, the long thoracic nerve, is the motor aspect for the serratus anterior. So if a patient's having any one of these signs or these symptoms, especially that medial scapular pain, that's what people don't normally come in for weakness. They come in for pain, but then upon your evaluation, and my favorite evaluation for assessing the serratus anterior, and I know there's a lot of them. However, I like the quadruped rock. If you want to see that video, go into the orthopedic section in ChiroUp. The quadruped rock is my favorite because usually I find this on my young patients. And on my young patients, I usually have one difficult person in the room, and it's not the patient, it's not me, it's their parent. So when you can show them that one scapula is flying off that thoracic cage because of weakness in the serratus anterior, as you rock them side to side and forward and backward, they can see the weakness and hopefully help get that person into care and get them treating that area to help prevent future injury to the rotator cuff or really anything in the shoulder girdle. So let's focus on this. So if you have a patient that comes in, they have that medial scapular pain. Is it notalgia paresthetica or is it long thoracic nerve neuropathy? So the things that I focus on is that when they come in, the exam is going to be pretty simple. Altered pinwheel touch, thoracic hypomobility, paraspinal hypertonicity, upper cross posture, and then really tenderness near T2 through T6. I'm thinking notalgia, along with obviously no weakness in the serratus anterior. Long thoracic nerve neuropathy is very similar, but now I'm going to be using the shoulder blade. I'm going to be looking for asymmetrical scapular control with my quadruped rock test, reduced serratus anterior. Really, you can just have them pick their arm up into forward flexion in the frontal plane. We're also looking for cervical provocative signs. So you can do things like the Sperling's test, maximal foraminal compression test. One test that is not anywhere in the literature, at least that I can find, that I use nearly every single time, is doing a really far good posture cervical retraction with a little bit of overpressure. And when you do this, you really pull the spinal cord. If you have any kind of compression or irritation of any of the nerves, you'll get reproduction. So it's kind of cool when someone comes in, they have pain going down the shoulder blade. You do a cervical retraction, like, yeah, that reproduces the pain that I'm feeling underneath my shoulder blade. So one of my favorite tests. Now, as far as treatment, it's going to look very similar. Obviously we're going to do manipulation, myofascial release, and exercise. When it is notalgia, I will really focus on postural correction and thoracic spine extension rehab. I think there's a lot of really good exercise you can do. I personally like the corner pec stretch. It's my favorite because one, you can get thoracic spine extension, but two, you're fixing the pecs. It's bilateral, which, unfortunately, as you get into the upper cross syndrome patients, it's going to be more of a bilateral postural syndrome anyway. But really, we're trying to manipulate in the office and then get them into a better posture when they're at home. Long thoracic thoracic nerve neuropathy is a touch different because we are going to focus a little more on the cervical spine as far as treatment. Of course, I'm going to get into releasing the pec minor, the scalenes, all those muscles that are really tight. But as a difference, I'm going to focus on things where I can get serratus anterior activation. You can do a lot of different treatments. There is actually a paper. It's not in. I'd have to find it, but the wall push-up test is the one they use to do the evaluation for this diagnosis, and the push-up plus is how they treated the long thoracic nerve. I'll try to find that and put in the show notes. However, let's focus on the next section for this podcast. The next section is going to be the thing that I hear most often in practice, is when I go through their OPPQRST, I go through my history, and what is going through my brain, and how can I explain it to patients, the difference between intermittent neurologic symptoms and constant symptoms. Now, before, years ago, I thought, well, it is once intermittent, and then it turns into constant. And really, it affects the nerve in the same ways. And that's actually not true. That these intermittent nerve symptoms are provoked by movement are fundamentally different than chronic constant neurologic symptoms. They actually reflect 100% distinct stages or etiologies of nerve dysfunction. And I'm going to explain that, I hope, in a clear way, because both of these are mechanical, but when it's intermittent, it's actually exciting the nerve. When it's a constant symptom, it's actually sedative to the nerve. And I'm going to do my best to explain this because this really does make a difference in how you treat the patient, and then most importantly, how you manage a patient and what the prognosis looks like for that patient. So first, let's start with intermittent. When you have movement provoked, and that's important. Movement provokes symptoms. There will be tingling or burning or buzzing or itching or sharp pain or zapping or whatever it does cause. You still have a functional nerve. However, the small sensory nerves, particularly the A delta and the C fibers, are becoming mechanically, or they could be, if there's a disc problem, could be chemically sensitized during tension, compression, or ischemia. So I want to explain this so that if you do an SLR, so let's say they're laying on their back, no pain, no problems. You start to perform the SLR and pain shoots down the leg. That's what I'm talking about. Movement provoked symptoms. You have an irritated nerve root. Now, these positive symptoms suggest a dynamic problem. This nerve is still capable of firing. It's 100%. Everything's good to go. However, a specific movement, a specific posture create that irritation, and it could be from really anything causing that. However, this is early entrapment. This is where your end range loading techniques, your manipulation, your mobilization, your exercises really focus on offloading that area, whether it's a joint or a region or a specific spot in a muscle, whatever it may be, resulting in compression or stretch of that nerve. We want to stay away from it because that area, that movement or that posture is causing that compression. Now, in contrast, constant, chronic numbness, weakness, reflex loss, trophic skin changes, atrophy, persistent sensory loss indicate a much more advanced, comprehensive, really probably compressive problem to a nerve that is causing ischemic neuropathy, where now we have these large myelinated sensory and motor fibers. They're beginning to fail. Conduction is not getting through at all through any of these fibers. So to put simply, intermittent movement-based symptoms are going to be a nerve is irritated and noisy, while chronic symptoms are the nerve is losing its ability to communicate. This is really going to change your diagnosis, your prognosis, and in all honesty, your level of concern. The teaching point is that we need to make sure that if we do have later compression and the nerves become quiet, this is something we want to really focus on and make sure we don't see these red flags now get worse because this persistent weakness is something that we need to do advanced imaging and possibly have a surgical consult if they're not getting better with our trial of care. Now, of course, let's go one layer deeper, because we can hear those things and we can test for those things, but let's discuss chronic and sustained neural compression. What does that mean? Because I think if we have an understanding of what that means, then it'll give us better ideas and how we can treat it. So when patients begin presenting with progressive weakness, whether it's sensory change, muscle atrophy, trophic skin changes, reflexes, burning pain, numbness, tingling, when all of these things start to be diminished, all the nerve fibers are involved. That's a big deal. Now, that doesn't happen usually. Normally, what we have is slow, steady compression to the nerve. And it's not just, all at once. It's gradual compromise of a nerve's vascular supply. So that's what's actually happening. So when you have intermittent symptoms, it's a mechanical problem that's exciting the nerve. When you have slow, steady compression to the nerve, it's actually cutting back on the blood supply of the nerve. And the cool part about that is that peripheral nerves actually have a very characteristic pattern by which they are compressed and which nerves start to fail first. Because peripheral nerves are remarkably metabolically active. They need constant blood supply to maintain axonal transport, membrane stability, really keeping up with that myelin, and of course, normal impulse conduction. So when blood flow is disrupted, nerves that require, nerve fibers to become metabolically irritable are really going to tell you how much compression is on that nerve. So which ones get it first? Which ones are the most susceptible to compression are actually the large, heavily myelinated nerves, which is kind of odd. Those should be the biggest, highest capacity, most resilient to compression, but they actually aren't because they have the highest metabolic demand, and you start cutting off blood supply, and unfortunately, the A alpha fibers begin to fail initially. What are you going to see? You're going to see mild motor weakness, reduced endurance, muscle inhibition, cramping, diminished deep tendon reflexes, all important things to check in your evaluation. Now, as ischemia and that mechanical compression keeps on going, the A beta fibers become involved now. Now, that's when you're going to get your numbness, your altered proprioception, your sensory loss, your coordination deficits. One of the things that you will also hear in your office is my hands feel thick or disconnected. My feet feel thick or swollen. Those are going to point back to an A beta fiber kind of irritation, or in this case, compression. Now, further progression, you're going to A delta fibers. This is when you're going to start to get your sharp pain, your cold sensitivity, your hypersensitivity of your skin. Those are the things that we're going to see when you get down to that level. And then eventually chronic compromise and compression reaches the unmyelinated C fibers. That's when you get the deep-seated ache, the burning, throbbing, and autonomic things, as far as skin changes and hair changes and nail changes. So when you get that deep-seated ache, that's constant along a dermatome, it's a bad sign. It's been there for a long time. We want to keep that in mind when we start to tell someone we can get them out of pain in 2 visits. That's probably not going to be the case, but can we help take compression off that nerve? Absolutely, 100%. Now, the fascinating clinical implication that I want to cover today that I think is really kind of cool is that when you understand these fiber types, you can estimate both the severity and chronicity of these neural compromise. But what's really cool is you actually probably understand the roadmap to understanding how they're going to recover. Because the way you take compression away from that, you're now going to reverse order those nerves start to come back. So as you start to take compression away from that nerve, the vascular supply is going to be getting better as you do manipulation, manual therapy, and exercise. The axoplasmic flow is going to start to normalize in the reverse order of those that were compressed. So as you start to bring blood flow back, they're going to see reductions in burning pain and hypersensitivity first. They're going to see improvements in sharp pain and sensory awareness and proprioception. And then finally, their fine motor skills, endurance, and strength are going to come back. So that's kind of cool. We can kind of understand how people are getting into their problem, and then we can also understand how things are getting better with our treatment as symptoms start to reverse order. Now, finally, what I want to talk about, the last section of this podcast was a humbling experience, which happens a lot in my practice and then also at ChiroUp, because I do work with people that are smarter than myself every day. Now, normally I'm referring to Tim, but lately it feels like nearly every single person on my team qualifies in this category. However, Tim does take the trophy this time. Last week I was lecturing in New Jersey, and I got asked a question on the stage, and I answered it confidently. And then immediately I had that internal sensation I was like, man, I hope that was correct. You know that feeling like where the audience nods, but like your amygdala starts to sweat? You're like, I hope that was right. But the topic was on nerve anatomy, and specifically how nerves transition from central to the peripheral nervous system. So naturally, I came into work on Monday and I started telling Tim about this interaction. And Tim kind of looks at me odd and kind of tilts his head to the side and mentions that nerve anatomy actually changes as the nerve traverses from central, from the spinal cord, into the peripheral nervous system. It turns out he was right. So luckily, I only bet him lunch, and he's a pretty cheap date. I think it was a Jimmy John's Ultimate Porker with easy mayo. Nothing says I lost an academic debate like processed ham. But to round things out today in the podcast, I want to discuss location, because he was right. Now, the nervous system actually does change. The nerve, actually, the fibers and its anatomy changes as it enters through or goes through the intervertebral foramen and goes, out to your fingertips. And the nervous system, nerve fiber organization changes actually quite significantly as it does that, as it goes through into the peripheral nervous system. And I had no idea. So here's kind of the nuts and bolts behind that. Near the intervertebral foramen, the nerve roots are still relatively immature. They're structurally compared to peripheral nerves. However, they're not the same. The dorsal and the ventral nerve roots have minimal, very minimal protective connective tissue. They have less robust blood supply. They have poor fascicular organization. And the reason I bring this up is because a nerve root is extremely vulnerable to ischemia, to chemical inflammation, to disc-derived cytokines from a disc herniation, to stretch, to mechanical deformation. So the hard part about this is that these nerve fibers haven't really neatly separated into the highly organized distal fascicles, the ones that I just talked about 5 minutes ago. And unfortunately, when you start to get compression or irritation at the intervertebral foramen, you can get any symptom. It doesn't follow the same pattern as a peripheral nerve. So you can get, with a little bit of compression or stretch, pain, itching, weakness, temperature sensitivity, autonomic changes, diffuse referral patterns that can go into the entire shoulder blade, in the front of the chest, and down into their side of their elbow. So keep that in mind, that they don't fit a nice specific pattern that you can read out of a textbook. Now, the important thing to remember is that once the nerve exits the central nervous system, its architecture becomes far more organized. Peripheral nerves develop fascicular compartmentalization, just like I talked about, in the last section. They actually have a thicker epineurium, which is good to resist compression. They have improved mechanical compression, and they have a more segmental vascular supply, and that's why they follow the patterns that I was talking about in the past section. Here's what that means to you and I, is that when you have distal compression of a nerve, it's going to produce predictable symptom patterns. For example, if you have compression of the medial nerve at the carpal tunnel, you're going to get sensory changes in the first 3.5 digits. If you get compression on the ulnar nerve at the elbow and get cubital tunnel syndrome, you're going to get numbness and tingling in the 4th and 5th digit. If you get fibular neuropathy, it's going to create localized loss of dorsiflexion. So the geography really does matter. Now, when you get proximal compression near the spine, you can get broad symptoms. So don't think that things have to fit into a book, that if you get compression of C5, it needs to be affecting the median nerve. That may not be the case. Also, nerves are more susceptible to chemical mediated symptoms. So a lot of inflammation, disc-related problems, even just sprains and strains around the paraspinal muscles can really cause a wide diffuse symptom and regional problem as compared to one distinct pattern that we'll see in a peripheral nerve. So I think this is where I want to, kind of focus into the take-home message, is that proximal nerve roots behave more like irritated neurologic tissue. The symptoms are going to be erratic and diffuse. Peripheral nerves are going to be more mechanically organized, cables essentially, and you're going to have very predictable patterns. This is going to be something that's going to help us make the diagnosis of, do I have a peripheral problem or do I have a more central problem? One condition that comes to mind that really does this this overview helps with is thoracic outlet syndrome. Thoracic outlet syndrome, we think about the problems that can happen in the neck can cause issues with the ulnar nerve. And what we know is that 90% of people that have thoracic outlet syndrome have problems with the ulnar nerve. However, since it's affecting just the fourth and fifth digit, it should help us delineate this might be more of a peripheral problem. Let's check out those scalings. Let's check out that pec. Let's check out that costo-clavicular region. And keeping in mind that when we do have issues with the costo-clavicular region, that's usually due to past trauma, an issue with the clavicle. However, if they have a very specific area of the hand or in the foot, if we're talking about one of those diagnoses that are causing problems, think peripheral. If it's a wide, diffuse, the entire shoulder, the entire arm, think more central. Now, to close out this podcast, I want to roll out something different that's going to happen next month. We're bringing on one of my clinical heroes, Tom Michaud. Now, Tom Michaud is basically my middle school crush of the rehab world. I've read everything he has written. I've quoted him in seminars. I highlight passages in textbooks. I just think that he is a tremendous person and obviously clinician, and he has absolutely no idea that we exist. So he's on a whole different level than us practicing chiros. But what's exciting is that after 2 years of doing this podcast, we're going to be bringing on our first guest. However, we're going to do it a little bit differently. We're not just going to be chasing the biggest social media follower or whoever can yell functional the loudest or whoever can look the best in a ring light. We are going to bring guests onto this podcast who have had a say in building it or are clinicians using it. And I think that's what's going to be kind of interesting. So our guests will be contributors, educators, or subscribers doing clinical things, either within or for ChiroUp. And it will lead to real conversations on how it'll help you, one, use the software, but also kind of help focus on what we need to do as clinicians as compared to big 30,000-foot ideas for the profession. My closing thought is going to go into the profession, though. Because I was on that flight back from New Jersey a couple of weeks. No, in fact, I was coming back from Nova Scotia. I was up there. Interestingly enough, the Canadian seminars are built a little different than U.S. seminars. I really like going up there. They have a different flow. I don't want to say they're more professional. They're not more professional because the seminars in the U.S. are very good. However, it is a different feeling. They're a lot more serious and very inquisitive. I've never answered more questions than when I was up there, which I really do appreciate. Anyway, back on topic. But I was coming back on the plane and I thought to myself, I literally ran out of toothpaste in Canada and I needed it by the time I got home. So I ordered some on Amazon and it was going to be at my front door when I landed. And I thought to myself, when Amazon first launched, people used it for one simple thing. For people who are in my age range, we bought books there. That's what it was like. I think they bought half.com, but it was a bookstore and that was it. It was a convenient way to save me money and really save me from going to the college bookstore. But then something kind of interesting happened. People realized that Amazon was not selling books. It was solving a friction problem and a price problem. So then consumers started to begin using it for other products when they started to carry other things. But the problem was that you could compare prices, but then you had to wait. It had to get shipped and it cost money to ship. So then what we found is that Amazon kind of pivoted and created more or had more products and found ways to get it to us faster. So really it was solving that friction problem of getting things cheaper and faster. And instead of wasting time driving to store and going from store to store, cutting out coupons, now I don't even look anymore. I just get on my phone. I trust that that's the cheapest price. And now I don't shop around at all. And now I don't buy big things. I don't buy books. I buy toothpaste on Amazon. And with no thought at all, because I know when I get home, I'm going to have a little box on my door with toothpaste. Now, I know there's a lot of people against Amazon, but let's be honest, it solves that problem and it does it every single time. It's interesting at how modern software, that's what it should do. It should solve friction. Now, we look at it as solving friction within a chiropractic clinic. And one of the things that I think is so interesting when I get to talk with really thousands of chiropractors on a yearly basis is how many different platforms we use. We use one for communication and texting, one for scheduling, billing, one for reminders, one for payments, one for exercises, one for documentation, and then something else for reporting. And yet somehow we have slowly drifted into this patchwork system that's kind of held together with passwords and subscriptions and sticky notes and workarounds, and that every extra login and disconnected platform or duplicate entry, meaning entering patients into different platforms, creates friction. And it seems manageable at first, but over time it becomes exhausting for us and most importantly for our staff. And I think that's what we're accomplishing. It's never done. However, I think that we are building our software differently to create more of an ecosystem that problem solves, that actually solves your problems quickly and reliably. It's not having online scheduling and patient communication and reminders and clearinghouse integrations and voice AI documentation and payments and exercises. It's not having different cheap subscriptions to all those. It's turning them all into one affordable option that's going to reduce friction and tech debt with your practice. And the reality is the software expectations, just like Amazon, is changing. Your patients expect convenience. They want to pay with their credit card. They want to have their credit card saved. They want to schedule online. They want to have their exercises printed or emailed or texted or in an app, depending on their age. Your staff is going to expect efficiencies. Your providers expect automations. They expect AI. And your older systems, they're not built for that. They don't have open APIs. Clinics find themselves trapped in outdated workflows with systems that feel slow and disconnected and filled with bugs and manual processes and really just consume our time. And let's be honest, we trade our time for money. So I think this is going to be where we continually focus. It's just like Amazon. I want to be the place that people trust that we can handle their problems. Our modern EHR system should become the operational backbone for every single chiropractic clinic in the US and also going into other countries, hopefully in the near future. And I think that when software becomes seamless, the entire clinic changes, communication improves, stress decreases on your end, staff function, they function better together when everybody's a little bit happier. Really, patients stay more engaged and providers finally regain something incredibly valuable, our time. So thanks for listening to the podcast. As always, if you found anything useful to your practice, whether it's one specific clinical nugget or story, tell a friend, like the show. Or if you didn't find anything useful, I'll give you Tim's cell phone number and you can submit a claim or a complaint to him. As always, thanks for listening to the show, and make sure to listen next month as we have Tom Michaud, our first guest ever on the show. Super excited to learn from one of the best.